Hello and welcome to Atossa Genetics. I'm Dr. Stephen Quay, the founder, chairman, and CEO of the company. In this video, we're going to talk about our Phase 2 clinical trial being conducted at Montefiore Hospital in New York City with our intraductal Fulvestrant program. In this trial, a systemic exposure of an anti-estrogen drug, Fulvestrant, is being compared to an intraductal administration of the same drug. The setting is the neoadjuvant setting, which is the time period between the biopsy that shows that a woman has an estrogen receptor positive breast cancer and the time of definitive surgery and radiation. So once the diagnosis has been made that a woman has estrogen receptor positive breast cancer, they will receive either a systemic exposure of Fulvestrant with an intramuscular injection in the buttocks, or an intraductal administration. They will then wait 2 to 3, maybe even 4 weeks, and the definitive surgery will be conducted at that time. The efficacy endpoint is looking at a biomarker of cell division called Ki-67. This is an antibody test in the laboratory where when you run it and look at a biopsy under the microscope, the cells that are dividing light up. And so, for example, in the biopsy specimen, you might see 5%, 10%, 20% of the breast cancer cells lighting up in any given specimen. And that becomes the baseline for that individual woman, for that tumor. The hope is then to look at the definitive specimen, the one removed 2 to 3 weeks later after the initial treatment, and see a reduction in Ki-67. That would be a sign of a positive efficacy. There are fewer dividing cells. You might actually also see dead cancer, which can be defined microscopically, and so that's the efficacy endpoint. With respect to the drug distribution, we'll look at drug both in the bloodstream and in the breast tissue. We expect to see that a systemic exposure will show a lot of drug getting into the bloodstream and a much smaller amount getting into the breast tissue. On the other hand, our intraductal administration should show higher levels in breast tissue and very little or no in the systemic exposure. And of course, we'll be measuring the standard side effects during this clinical trial program. It's involving about 30 women, at Montefiore Hospital in New York City. So the current paradigm for the use of intramuscular administration of Fulvestrant is an approximately once-a-month administration in the buttocks. It's very expensive. It costs about $12,000 per dose, or over $140,000 per year per patient. It addresses the estrogen receptor fraction of breast cancer patients, which are upwards of 70-75% of the 250,000 women each year who are getting breast cancer in the U.S. So my hope is that this will be what I like to call a one-and-done procedure, that when a woman has her biopsy showing she has estrogen receptor cancer, she'd be administered this soon thereafter. It's an office administration. It takes 15 to 20 minutes. You put a lidocaine block in the nipple, so there's very little pain. It's much like a dental procedure. And that at the time of definitive surgery, there'll be a reduction in Ki-67, showing that the tumor is not dividing as much at the time of surgery. So we're anxious about this program, and we have high hopes for it. Please keep tuned for any further developments. If you'd like more information, you can go to our website at atossagenetics.com. Again, thank you for your attention.